An anteromedial portal and an anterolateral portal are routinely established. Diagnostic arthroscopy is performed to assess any injuries of cartilage, ligaments, and synovial tissues. Adhesion band of hyperplastic synovium is released with the shaver, and the injured area of the OLT is overall inspected with the probe. Initial treatment of the OLT is composed of curettage and debridement of any unstable cartilage and osteochondral tissue. Defects of superficial cartilage and cystic components are preliminarily debrided with curette and shaver to a stable circumferential rim. An accessory anteromedial portal is created 2 cm above the standard anteromedial portal. After a guide needle being placed on the arthroscope, a skin incision is made, and a blunt trocar is used to penetrate the capsule. Visualization is achieved through the accessory portal, while the anteromedial portal serves as the working portal for instruments. All cystic components and necrotic bone are debrided with curette and shaver to a stable circumferential rim. The sclerotic cystic wall is thoroughly cleared until intact subchondral bone is exposed. Microfracture awl is introduced and subchondral channels to 5 mm in depth are created, spacing the channels 3 to 5 mm apart across the entire surface of the lesion. Subchondral channels are also made on side wall of the injured area. The borders of the defective area are checked again with probe. The diameter and the depth of the lesion are measured. The ipsilateral Gerdy's tubercle is chosen as the donor site for cancellous bone harvest. A 3 cm oblique incision is made, and the cylindrical bone is harvested from the tubercle using the harvest tube. The tube is advanced approximately 10 mm with a hammer, then rotated fully around itself until being removed. The underlying spongiosa autograft is harvested with the curette. A specifically designed delivery guide apparatus is applied in implantation of the spongiosa autograft. The apparatus consists of a sheath and a core rod. A groove lies on the upper surface of the sheath, which avoids impingement with the distal tibia when the apparatus is inserted through the narrow cavity. A dry arthroscopic technique is applied, with the fluid within the joint being aspirated using a shaver aspirator. The apparatus is introduced into the cavity through the accessory portal with visualization from the anteromedial portal. Cancellous bone is first placed in the sheath, and then the core rod is inserted into the sheath to push the graft out and insert it into the lesion. The graft is impacted with probe and curette. A flattened surface even at the level of the subchondral bone is maintained. After the ankle joint being extended and flexed for several cycles, position of the spongiosa autograft is re-examined to ensure it is fixed in the defective area. Thanks for your attention.